questions answered to what an exchange actually is, what some of the tax implications are, how it's going to affect your health insurance, and I think you guys are going to be very thankful that you took the time to come here this morning. So our first speaker, well, and I'll just say that we are going to have speakers through about 9:20, and then we do have some ladies that are going to hand out some pads of paper. Perhaps, if you guys wouldn't mind, there are pads of paper down there in the back of the room. And if you have questions while people are speaking, if you wouldn't mind writing those down, then we'll collect those around 9:20ish, and then we'll have time for questions and answers at the end. But if you could hold your questions while people are speaking, that would be fantastic, so we can get started right up here. Restrooms are right outside that entry gate, and we've covered all of everything we need to cover, right?
Coffee, water.
Coffee, water over there. There we go. All right. So first up, we have Maureen Lawson. Maureen has worked in the insurance industry for more than 20 years for both large and national carriers and regional health maintenance organizations. Her primary responsibilities for much of the past 12 years has been product development, product management, and distribution management. Maureen is currently the Director of Commercial Business Development for Network Health, with a primary focus on healthcare reform strategy and implementation.
So, can everyone hear me? Well, thank you for being here this morning. I'm pleased to be here and to speak with you. I appreciate the opportunity. What I wanted to do was focus on what is commonly called ObamaCare, or the Affordable Care Act, and I say that with some difficulty because I don't believe that it is affordable or is going to make things more affordable. But I wanted to talk to you a bit about the implications for carriers. You've probably heard a lot of talk about rates are going to go up, premiums are going to increase, things are going to change. And I think it's important that you understand some of the reasons why that's going to happen. Without politicizing, I would say that insurance carriers have certainly been villainized over the past 5 years in regard to health care and the cost of insurance premiums. I do like to remind people that the Affordable Care Act has two goals, if you will, which are to lower cost and improve care. And the Act itself really does not contain components that do that. You may have heard for a time it was changed from healthcare reform to insurance reform, and it went back to being called healthcare reform. Two things that carriers don't do are set rates for the cost of care. So when you go to the doctor, we really are not the ones that set what the doctor charges or the hospital charges, and we don't deliver care. So the tasks that have been set upon carriers to lower costs and improve care are somewhat out of our control. And what I want to talk to you about are things within the Affordable Care Act that are the challenges that we're working with today to try to keep your premiums affordable. And if you want to go to the next slide, please. You may have seen this. This is truly a reflection of all of the regulation that comes on to health insurance plans. So this is real. This isn't a joke. This is the regulation that health plans deal with from all the different arms of the government, and this law, the Affordable Care Act, has added to that substantially. This is how I spend my time. I was unable, unfortunately, to find a slide with a lot of paperwork in a female, but I guess that's a whole different subject that we won't address here today. But the regulations are immense. If you heard at the beginning that the law itself was over 2,000 pages, there have been thousands of pages beyond that, because within the law there were 1,039 references to the Secretary, Kathleen Sebelius, the Secretary of Health and Human Services, and those 1,039 references indicate areas within the law to which there were no rules, there was no depth, no explanation, and that those rules, depth, explanation is to come from Health and Human Services. The law was passed in March of 2010. Open enrollment for individuals on the health exchange begins in October of 2013. We still don't have the rules. We're still waiting. They come out with proposed rules, and insurance carriers and special interest groups and lawmakers read the proposed rules, have a period of time which they can comment back to HHS on the impact and suggestions for improvement, and then the final rules come out. So The proposed rules started coming out in November. So with less than 10 months, we're still waiting for rules. Well, what changes? Pretty much everything changes. Access, we've all heard about guarantee issue. Anyone who, you don't apply anymore, you enroll because you can't be turned down. So any individual that enrolls will gain access. There are no pre-existing conditions. So in the world today, you may know that if someone has a condition, a carrier can say that condition's not covered for a certain period of time. And that won't be allowed anymore. Dependents will continue to be covered on their parents' plan until the age of 26. And there are new access points. We've heard about the exchange. So access to insurance can be gained on the exchange. It will also continue to be able to be gained off of the exchange. So there's two markets now, on exchange and off exchange. Now, I'm not advocating that the change to access is good or bad. I'm just going to tell you it's different and it changes everything. And again, I want to talk to you about how it changes. Benefits are changing, and I'll talk about that in a bit. Premiums are going to change. There is a purchase or pay a penalty. So every individual, with many exceptions, if you will be required to purchase health insurance. If you hear about the individual mandate, some controversy around the individual mandate, it's about the fact that the fine, if you will, for not purchasing insurance is $95. I'm going to talk to you in a second about premiums for individual insurance, and you make your decision if it's worth paying $95 in fine or paying premiums. Taxes and fees are spread across industry, and not just the insurance industry, but physicians and medical device makers and tanning booths, if you've heard of that. And then the increased administrative burdens, which are many. I have more slides than I can get through, so I will speed here. An exchange is a marketplace, and you may have heard the exchange referenced to be something like Travelocity. So you'll be able to go online, you go in, you put your zip code, you put your gender, and it'll come up with a series of benefit plans from various carriers, and you can make your choice. So the intent is that this will be very easy to use. There are certain benefits that are required by all carriers, so they should be light and not confusing. And at the end of the day, basically, our belief is the person will pick the rate, because the belief is all else is equal. So the exchange is a marketplace where you purchase. Essential health benefits. These are a series of benefits that every carrier with individual and small group insurance must cover. It is 10 categories. So there are different benefits within these categories, but these 10 categories must be contained within every benefit plan offered in individual and small group insurance. The reason I have some underlined and italicized is those are benefits that typically you do not see or you see as an option on individual health insurance and small group. Typically today you may have some carriers that offer maternity as a benefit. Going forward, maternity is embedded in all plans. So you don't have the option to purchase maternity or not purchase maternity. Today, dental typically is not offered inside of your medical plan. Effective January 1, 2014, pediatric dental must be embedded in all health plans. Pediatric dental means dental up to age 19, everything but non-medically necessary orthodontia. That sounds great, but let's not forget it comes with a cost. You know what your dental insurance looks like today. You put peds dental into a health plan, it's going to cost. You put maternity in every plan, it's going to raise the cost. So even if, and this must be in every plan, so even if you had a child-only plan, maternity is going to be included. There's no option to remove any of these benefits. Premiums, the way the premiums are calculated changes, and it changes in a large way. One I'll focus on is today, the premium between the youngest and the oldest can be 5 times. Okay, so it's a 5-to-1 ratio. That's being compressed to 3-to-1. So a 27, pardon? Lowest to highest. Well, actually, on my next slide, I have an illustration of it. So it is saying that if I'm 27 years old, a 63-year-old can have a rate only 3 times more than mine. Today, that's 5 times more. So when you push that down, it has to come up on the other end. So rates for the younger people are going to increase substantially. Family composition, age bands I talked about. Today, some carriers might rate up to 5 kids or all of the children. You know, you have mom, dad, and all the kids. In the future, 3 are the maximum that can be charged for. So if a family has 10 children, they get charged for 3. If they have 3, they get charged for 3. If they have 2, 2. But again, that compresses the rate ability. You can still rate by geographic area, and you may have heard that there can be a 50% rate up for tobacco use. Influence, as the rules come out, you know, it's clear that tobacco users have higher health issues, certainly later in life, so you can rate up for tobacco. What's happened now, when the proposed rules came out, it states that if a tobacco user enrolls in a smoking cessation plan, you have to take the 50% off. They don't have to stop smoking, they don't have to complete the program, they simply have to enroll, and then the 50% is rolled back. So really it becomes a non-issue, although as a small employer, you'll have to offer the smoking cessation program for them to enroll in. Prohibited factors that are used today, health status obviously can no longer be used. Claims experience can't be used. Gender, you can't rate. You know, men and women have more health issues at different ages, so premiums reflect that today. That will no longer be allowed. Industry classifications will no longer be allowed as a rating factor, and small group size will no longer be allowed as a rating factor. So it's really age, composition, and geographic area. The age band compression, this is just showing an example. I have to put my glasses on, I can't read. Today, a 24-year-old may have a premium of $1,200, and a 60-year-old a premium of $6,000. And that reflects the difference in age and the medical use that you have, the medical issues you may have with age. When you compress that down to a 3-to-1, the 24-year-old's premium goes up to $1,740, which is a 45% increase, and the 60-year-old's comes down to $5,220. That's 13% less. When you hear about premiums increasing, this 45% on the 24-year-old is reflective of the change in age compression only. The Society of Actuaries came out with a study this past Friday that indicates in Wisconsin the increase on individual premiums. And where did Michelle go? Michelle mentioned that she has an individual plan. Oh, I'm sorry, right there. Huh? With Network Health, the estimate that has come out is that premiums are going to increase 80% in the state of Wisconsin. And their study was looking at our demographic, our ages, the amount of people we have on Medicare, what the uptake in the exchange is going to be. That estimate's 80%. Wisconsin and Ohio have the largest, both at 80%. So I can't tell you that 80% is right or wrong because we're still waiting for the rules. We can't design the benefits or price the plans because we don't know the rules yet. This is, again, just looking at the age quickly. This just shows us that today we have 42 states that have greater than a 3-to-1. Greater than that 3-to-1 age ratio that I mentioned. So in 42 states, the impact of just that is going to be somewhere around 40% on premiums. Taxes and fees, I won't spend a ton of time on these. I'll point out a couple, but these are the taxes and fees that are being put upon the insurance industry. I'll point out the reinsurance program. I'm not going to explain what it is. I just want to point out to you that this fee starting in 2014 is $5.25 per enrollee, per member, per month. So Network Health has about 85,000 commercial members. This is an additional $5.25 for every single member, and that's going to be passed on. So when I say age is going to increase at 45%, this is going to increase it. We have a Patient-Centered Outcomes Research Institute fee. That's going to be $1 for covered life per member. That's going to have to be passed right on. We have to price in. Risk adjustment is another $1. And then the risk corridors and the annual health fee, which is indicated to add about $5,080 to a family's premium over 10 years. So these are taxes and fees that we have to pay that are going to have to be passed on. And the reason that I really want to share all of this with you is I want you to understand and talk to your coworkers, talk to your friends, and talk to your family and understand that these are things that are part of the law. So it isn't Network Health and United Healthcare and Humana saying, we're jacking up the rates. It's a result of the requirements within the law. In Wisconsin, we've had a very competitive and a very carrier culture. We live in a unique state. We have a lot of carriers, we have HMOs, we have health plans throughout the state. That's not common. Competition in our state is very strong, which means prices stay in check because we're competing against each other. You have other states that have one primary carrier or maybe two carriers. We have a wide expanse of carriers. We're fourth in the country in terms of uninsured. Our uninsured population is 10.4%. It's not huge. Having an uninsured population isn't great, but it's not huge, and some people choose also to be an uninsured. We can't forget about that. Wisconsin consistently outperforms providers in other states in terms of quality of care. This talks about the Agency for Healthcare Research and Quality. Based on 171 measures, we're second only to Minnesota in the country in terms of quality of care. And I indicated the recent study by the Society of Actuaries and the 80% increase on the individual market. My point here is we have a pretty nice apple cart in Wisconsin. We've had a very competitive market. We have great quality of care, and it is being disturbed in a very great manner for very, very few rotten apples. And it makes me feel like that. So with that, I will say thank you and pass it on to Chris.
Do we clap for that?
I'm not the good